to medical grant rounds. Just a quick reminder, I ask you to please enter your questions in the chat at the end of the presentation. And please fill out a brief survey at the end of the presentation to let us know that you were present today. We have a speaker coming to us courtesy of the Division of Dermatology today, and I'd like to ask Dr. Linda Moreau, the Chief of the Division of Dermatology, to introduce our speaker today. Linda, the floor is yours.
So it's of course a great pleasure and honor to introduce Dr. Mathieu Powell. He graduated from our program in 2014 and then went on to do fellowship for 1 year, advanced cutaneous therapeutics, both at McGill and Toronto. And then when he came back, he became co-program director for 2 years. And he has been an incredible teaching asset in our program. His teaching and his presentations are highly valued by our residents. He's focused in psoriasis with complex care, immunologic, biologics, and he also has a part-time practice outside of the institution in medical dermatology and cosmetics. And he has won 2 years in a row the Canadian Dermatology Association Award for Excellence in Clinical Teaching. So I really think we are in for a treat for Dr. Powell's presentation today. So without further ado, please tell us everything you know about blistering disorders.
Thank you very much, Dr. Moreau. That's very kind of you. I'll try my best to live up to the expectation. Thank you very much for the invitation today. I'm very happy to speak amongst peers. Today, I'll be discussing a very broad topic in dermatology, an approach to blistering cutaneous disorders. I tried to be a little alliterative here by emphasizing that some of these blisters are benign, some of them are more dangerous or belligerent. The objectives of this presentation are to appropriately identify benign to severe blistering skin diseases while focusing on the major ones. To understand at the immunological level what occurs in the skin and why it's happening. And ultimately to review the multidisciplinary management of these severe blistering diseases and really to understand what happens or our dermatologist's role when we are consulted on these cases. I also want to take a little bit of time to dispel a few myths about certain aspects of dermatology. We sometimes get referrals for a condition called bullous pemphigus, which is actually not a cutaneous diagnosis. It's actually not a diagnosis at all. It's actually an erroneous amalgamation of two terms, bullous pemphigoid and pemphigus vulgaris. So one of the goals will be to distinguish these two entities for future consultations. Another important myth to dispel is that there are no cutaneous emergencies. I guarantee you that there are cutaneous emergencies, particularly blistering disorders can be detrimental with regards to morbidity, mortality, erythroderma, drug eruptions. And might I add that when one of our colleagues or yourselves have a rash, I seem to see it as quite an emergency. And finally, and perhaps most importantly, a myth to dispel is that dermatology is certainly not easy. It is certainly not simply acne and Botox. And in fact, when I do hear this, I tend to whip out my dermatology parcel tongue with 17-syllable diagnoses, mostly to emphasize that cutaneous disorders can be quite complex, difficult to manage, and important to recognize them early as their gravity may drastically affect patients' lives. I do not have any conflicts of interest. So what is a blister? Well, a blister or bulla or vesicle, for being a small bulla or blister, is basically a collection of fluid within or under the epidermis, and its diagnosis truly depends on the site of the intercellular split, so where it occurs at the level of the epidermis or dermis, and what type of cell predominates its content within the fluid. Blisters or bullae can occur in a variety of different shapes and sizes, in a variety of different numbers or specific locations. For various reasons, they can be quite widespread. Sometimes they're very local or focal or due to external traumas. However, they can be quite detrimental and so extensive that they can cause extensive morbidity, mortality. Why does a blister form? Well, this implies knowledge of the cutaneous anatomy. So really, we're looking at the level of the epidermis and the dermis and properly identifying what structures lie there. So if we're looking at the level of the epidermis, we have these cells called keratinocytes, which I'm sure we're all familiar with, which are surrounded by adhesions, or desmosomes to be more precise. They're combined with calcium-dependent molecules called cadherins, which are made up of either desmoglians or desmocollins. Purposes of the terms are not necessary, but basically once that's broken, those cells tend to separate in a process known as acantholysis, and it causes an intraepidermal blister, so a blister truly within the epidermis. Conversely, if you're looking at the epidermis onto the dermis, so the dermal epidermal junction, we have a specialized structure called a hemidesmosome, which is made up of molecules called BPAG1, BPAG2, laminins and integrins, which we'll talk about later, which tend to attach the epidermis onto the dermis. And if those molecules are disrupted, then the entire epidermis will lift up over the dermis. This is called a subepidermal blister. Now, the dichotomy between an intraepidermal blister and a subepidermal blister is quite important for diagnostic purposes. If you imagine that the upper layer is very thin, so you have a very thin roof within an intraepidermal blister, that blister will be much more friable. It might more easily deroof, which will leave you with erosions. You might not actually see intact blisters. Conversely, a lesion that has a subepidermal blister, you can imagine that because the entire epidermis is focally involved, the wall is much thicker. And so the blisters tend to be much more thick or turgid. So this is the clear distinction clinically in two conditions we identify as pemphigus versus pemphigoid or bullous pemphigoid. On the left-hand photo, you can appreciate that pemphigus tends to have very friable blisters. They easily deroof, leaving erosions. And in bullous pemphigoid, the blisters are so intact and turgid that they are much more prominent. Which blisters are dangerous? Well, one could argue that any blister is dangerous, technically because the skin-cutaneous barrier is disrupted, and that includes an increased risk of infection, but also fluid loss, allergy, and inflammation. However, some blisters are a bit more alarming than others, so we'll go through some cases to identify this. But the most important factor is to determine the underlying cause. So what causes blisters? Well, there are many different causes. First of all, some patients or humans are born with a predisposition to having blistering disorders. Their attachments, whether in the epidermis or in the subepidermis, are suboptimal. There are infections or inflammatory causes. There are maybe autoimmune causes or external factors or allergies. Some cancers, lymphomas, leukemias can cause blisters, and a wide variety of extrinsic and intrinsic factors like trauma, burns, edema, diabetes, or deposition disorders that can also lead to blistering. So how do we approach this? We'll go through some cases. Case one. So we're starting off with a very young patient. This happens to be a baby, recently born, or in the last 6 months. Skin blisters arise right from birth upon very minimal trauma. The skin is extremely fragile, leaving denuded erosions. This is sometimes referred to as a butterfly child. For purposes of this talk, it's difficult to know what you're thinking about, but I will give you some hints and then you can come up with your diagnoses upon yourselves. This is referred to as epidermolysis bullosa. This is part of the genetic forms of blistering diseases. So this baby is born with a propensity to blister very easily. So let's look at this at a mechanistic level, at the level of the epidermis. We're looking at the dermal epidermal junction, the epidermis onto the dermis. So if we look at this structure, we've got a basal cell that's located at the base of the epidermis that's connected by what's called the lamina lucida onto the sublamina densa. If there's a break within the epidermis, we develop a blister cavity. This is likely due to defective keratin filaments within that basal keratinocyte, and that means that there's a genetic susceptibility. So this leads to a condition called EB simplex, which can be focal, but it can be very widespread. So these babies or these children grow up with a very high risk of developing blisters, high risk of infections, and granulation tissue. They may have esophageal involvement, mucosal or laryngeal involvement, so their cases are potentially very severe. Sometimes the mutations are involving molecules that involve lower than the basal keratinocyte or within the lamina lucida. And so there can be some involvement of also muscular dystrophy, pyloric atresia, and others. So if we look conversely to the lower aspect of the epidermis, you can have a genetic mutation causing problems in collagen in the sublamina densa. This can be so severe genetically that instead of developing blisters, we go directly to the concept of scarring. And this is an example of what we call a mitten deformity, a dystrophic form of epidermolysis bullosa. This can be quite dramatic, as you can expect for motility, but also in the context of scarring, prolonged scarring can cause risks of malignant degeneration like squamous cell carcinomas. And on top of it, there can be some oral, esophageal, and renal involvement as well. Again, these patients have a difficult life. Interestingly, so this we were talking about a genetic component, but if there's an antibody or an autoantibody to that same collagen, we may see a similar type of disease that occurs mostly in adults called epidermolysis bullosa acquisita. So the development of the same types of blisters or scarring on the same areas, but a slightly different type of presentation. But for the purposes of this talk, quite important for us in internal medicine to understand, because this condition may be linked to other autoimmune conditions, particularly inflammatory bowel disease, lupus, rheumatoid arthritis, thyroid disease, and diabetes. So when we're thinking about genetic forms of blistering, the only real methods of diagnosis is through diagnostic microscopy. We use transmission electron microscopy to look where exactly those antibodies are targeted against known structural defects amongst the epidermal basement membrane. So based on where the blister localizes on the microscopy, we can better identify if it's a superficial, mid, or deep type of blistering, and ultimately the prognosis of patients. Patients who have genetic forms of blistering have a very difficult life. They're constantly leading to minimal trauma blisters, and still there's no specific treatment for these. Unfortunately, the treatment is mostly aimed at minimizing infection, at minimizing mechanical trauma on a day-to-day basis, ideally by wearing looser fitted clothing or padding on bony prominences, and a variety of non-adherent dressings, which we're often consulted for on the ward. Interestingly, there is a concept of gene therapy or genetic mosaicism, which can be used by using or harvesting skin tissue of normal tissue and transposing it into areas of involvement. And that may help to produce more normal cicatricial tissue and ultimately less scarring. But of course, the treatment is very multidisciplinary and our goals are to maintain complications. So let's move on to some more inflammatory cases. Case 2. This is a 30-year-old man with flaccid, transparent, or pus-filled bullae. You can appreciate here there's sort of a collection of pus that seems to hang down due to gravity. This is called a hypobian sign. Blisters rupture very easily. They leave dry erosions. And interestingly, you can appreciate that around the mouth, there's some peri-oral golden yellow crusts. The patient also happens to have fever, diarrhea, and weakness. This is a condition called bullous impetigo, much more common, a cause of infectious forms of bullae. If we look again at the histology at the skin cutaneous level, we're looking a little bit more analytically at the levels of the epidermis, the stratum corneum, granulosum, spinosum, and germinativum. In this context, we're looking at the very superficial aspect of the stratum granulosum. This is where the Staphylococcus aureus toxin tends to exert its activity. It acts on specific desmosomes, a particular antigen, desmoglein-1. So it creates very superficial blistering. The blister wall is very superficial and may be very easily decornify or fall off. So interestingly, in this context, we're looking at an infectious pathogen that causes a superficial blister. But again, if we have autoantibodies targeting that same antigen, desmoglein-1, there can be a very similar cutaneous presentation. The dichotomy here is bullous impetigo, which is that infectious condition, or pemphigus foliaceus. The same target is being targeted, however, due to a different underlying cause. So this can pose a conundrum in terms of diagnosis, but you might appreciate that bullous impetigo tends to have a little bit more of that yellow golden crust due to the Staphylococcus. And interestingly, further on, cases that are more autoimmune in nature, like pemphigus foliaceus, can be much more widespread, sometimes leading to erythroderma, which we'll discuss in a bit. Now, there are a wide variety of other infections that can cause vesicles and blisters in the context of herpes or herpes zoster, or in the context of varicella, a wide variety of blisters. Certain fungal infections can cause bullous tinea or scabies when it's quite prominent, and even certain forms of rare bacteria that you might encounter in certain beach destinations, for example, Vibrio, which can cause hemorrhagic blisters. If we look a little bit more closely at the level of a herpetic infection, similar to a bacterial infection, however, causes more destruction of the keratinocytes, and we can have these little inclusion nuclei. But for the purposes of this talk, again, we're looking at a very superficial blister. And again, you might see a patient on the ward or in the emerge who has no intact blisters because that blister is so thin and only presents with grouped erosions. Further, other infectious organisms can cause blisters, for example, bed bugs, or arthropod bites. So these eruptions tend to be quite inflammatory. The inflammatory process goes so deep that it tends to produce an uplifting of the epidermis. And so the blister presentation tends to be closer to the turgid or tense form of blister as opposed to a superficial one. You might have heard of a concept called breakfast, lunch, and dinner, where we used to think that bugs would have their first bite, then skip over, have their lunch, and then their dinner. We now understand that bed bugs generally bite in groups. And so 3 different bugs might have created that same pattern. Although the blister presentation is much more inflammatory than other infectious pathogens, and sometimes so inflammatory that when they heal, they'll leave you with a black eschar. For example, this would be a result of an arthropod of the spider type, which is called the brown recluse spider, and ultimately the therapy may be much more anti-inflammatory. So you can anticipate that in the context of an infectious form of blister, we're looking for signs of infection on the cutaneous and historical exam. We're looking for the culprit organism, so that might involve requiring cultures for bacterial, viral, fungal, or burrow scraping if you're suspecting scabies. Obviously, we'll want to treat with the appropriate anti-infective therapy. If there are any bugs or stingers, you'll need to remove them. You might need to use a wet, dry gauze to remove crusts. And in the context of an inflammatory process from an arthropod bite, you may need anti-inflammatories like cortisone. We sometimes require the help of our infectious disease colleagues to rule out sepsis, particularly if there are systemic symptoms. And I do want to point out that when you're traveling, if you have large arthropod bites, it may be considered normal if you're not used to the surrounding environments. However, if all of a sudden a patient starts to develop very widespread or very inflammatory blisters or immune reactions to arthropod bites while in their home city, this could be suggesting the development of an autoimmune or irregulatory immune problem. So these patients should be tested for HIV and potentially a CBC to make sure there's no development of leukemia. Case 3. This is a 34-year-old man who presents with very itchy, tense, and eroded blisters on the right arm exclusively. He says the only thing that seems to be new is he has a new baby and he was wiping his baby's bottom and he needed to use the wet wipe on his arm because there was some splattering. This is a form of allergic contact dermatitis. Obviously, there's a little bit of pathogenization, but the source is likely external from contact. And baby wipes have had slightly negative reputation because more and more we're seeing that these are contaminated or contain a preservative called methylchloroisothiazolinone, which is also found in a bunch of other products like shampoos or lotions, but ultimately some patients are quite allergic to them and develop these rip-roaring blistering eruptions. Now, not all cases of allergic contact dermatitis are blistering, but they obviously have one thing in common, is that they all occur in an area of contact application. For example, a nickel belt buckle in a localized area, henna tattoo only in the area of the henna tattoo, leather from sandals. The only exception would be, for example, what's called an ectopic contact dermatitis, whereby you may not have an allergic response to the nail polish around the nails or the fingers, but once you touch your eyelids where the skin is much thinner, that's when you'll develop the contact dermatitis. So a common misconception is, I have a rash, I have a blister, what have I done yesterday or today that might be different? When in reality, many of us are aware that allergic contact dermatitis, or for example, drug eruptions, happen to be delayed type 4 hypersensitivity reactions. So they're combined with a sensitization phase, which may last anywhere between 5 to 14 days or longer, and an elicitation phase, which generally lasts about 24 to 72 hours. So upon repeat exposure, it tends to happen more rapidly. Just for argument's sake, this is a very simplified version, but basically, if an allergen is exposed onto the skin, it will be incorporated by Langerhans cells, ultimately dermal dendritic cells, transposed to the lymph node, where it will sort of create, transpose or transform naive T cells into effector T cells, and ultimately goes through the vasculature to go back to the site and ultimately create inflammation combined with neutrophils, mast cells, and macrophages. So really, if you're suspecting a problem or a potential external factor causing that blister or rash, you should be looking at exposure from at least 2 weeks prior. And in dermatology, and as well in by our colleagues in allergy, we do what's called patch testing, which is a specific form of allergic response testing to known compounds that we might tend to use on our skin: shampoos, lotions, fragrances, certain metals, based on a person's individual habits or potentially on their occupation. And through a week to 10-day testing, we might be able to identify certain exposures that would be causing this underlying eruption. Now, interestingly, certain contacts or certain exposures or allergic contact give us visual clues. So here you might be able to appreciate that the blisters along this area are quite linear, and there aren't that many things that cause linear vesicular dermatoses. In fact, one of the most common things to elucidate is whether a patient has had a plant exposure called phytodermatitis, the most common of which is through the Anacardiaceae family or Toxicodendron species that you might be familiar with as being poison ivy, poison sumac, or poison oak. And mostly it's because these contain a pentadecacatechol in oleoresin called urushiol, which can cause some severe presentations, and it can cross-react with certain other molecules, for example, mango or mango rind, particularly cashew oil, or other catechols that we might find, for example, in ginkgo. And ultimately, if you would consume it and expose it, you may develop a very severe eruption called a systemic contact eruption. So the management of a blister when it's in the context of an allergic response is to eliminate the offending agent, of course, if possible, to dry out the blisters using wet, dry compresses, and to use anti-inflammatory therapies, particularly topical corticosteroids, or may require systemic corticosteroids, especially in the context of poison ivy. Patient education is key, basically to prevent the reoccurrence by preventing the re-exposures, and patch testing can be useful to help patients do that. Case 4. So we're starting to get a little bit more involved here. This is a 63-year-old man who presents with a history of inflammatory bowel disease with multiple intact and eroded blisters on the trunk and lower extremities. Interestingly, he happens to note that he has significant unexplained weight loss. So already, I think alarm bells are ringing. The blisters have an erythematous, which means red border, to a violaceous border, so slightly purplish in color. And then they tend to transform into blisters with an undermined border, which basically means the border of the blister or the ulcer is hanging over the edge. This is a condition called pyoderma gangrenosum. Now, it may be a little different than what you are known to expect when you consult for pyoderma gangrenosum. This is the particularly bullous subtype. And this is important to know, the fact that there are different presentations of pyoderma gangrenosum. The classic or ulcerative type, of course, happens to be on the lower leg, but 50 to 70% of patients do have an underlying inflammatory or internal medicine problem, particularly inflammatory bowel disease, and particularly again in the classic or ulcerative form, but also in pustular forms. Now, arthritides, particularly seronegative or spondyloarthropathy or rheumatoid arthritis, is seen in the classic ulcerative form. For the purposes of this talk, patients who have pyoderma gangrenosum of the bullous type are commonly, or about 20% of patients, are associated with a hematologic malignancy, particularly AML, CLL, hairy cell leukemia, and myelodysplastic syndromes. And finally, the granulomatous or vegetative subtype is a little bit more rare, less properly elucidated, linked to chronic renal failure, maybe overlying an underlying Wegener's granulomatosis and certain autoinflammatory syndromes, but a little bit less common. So the process of an inflammatory blister is that it happens to be a reactive process. So the inflammatory phenomenon is so prominent in the dermis that it almost sort of pushes up the epidermis. In some cases, these neutrophils or lymphocytes tend to create a pretty prominent eruption. So this is another example of bullous pyoderma gangrenosum. But sometimes it doesn't quite push it up to create a blister. It almost sort of gives a pseudo appearance of a blister, so a pseudo vesicular presentation. This is called sweet syndrome, again, a neutrophilic dermatosis. And sometimes it does push it so well with a sort of a band of lymphocytes. This is a particular condition called lichen planus, and there is one of its 15 variants, which happens to be a bullous type. Erythema multiforme is a commonly used diagnosis you might be familiar with. Its name inherently means it has multiple different red presentations, but the classic, and which include bullous forms, but the classic target lesion may have at its center a blister or a dark dusky macule or papule, and then is surrounded by an erythematous halo, and then ultimately a red halo. When it's widespread, however, we're starting to think about a little bit more internal diseases. Particularly, I think every infection has been linked, well, I can't say every, but many infections have been linked to erythema multiforme, including now COVID infections. But in the context of more common, we're talking about herpes simplex or cold sores recurrent or mycoplasma pneumonia. Certain drugs like NSAIDs particularly, or exposures like poison ivy, as well as certain systemic diseases, IBD, lupus, and Behçet's have been linked to recurrent blistering disorders of erythema multiforme. Another condition you might be familiar with, vasculitis. When you think of palpable purpura or purplish lesions that don't fade upon pressure, or petechiae, when it's very prominent or of a bullous nature, we tend to worry a little bit more about an increased risk of systemic vasculitis or of a particularly underlying cutaneous disease. That being said, any patient who has vasculitis should still be evaluated for underlying conditions, including infections, particularly strep or URTIs, again, inflammatory bowel disease, certain drugs, again, NSAIDs, ACE inhibitors, and certain neoplasms. We're talking about mostly solid tumor, but hematologic malignancies as well. Unfortunately, we can do sometimes all the tests imaginable, and 50% of cases of vasculitis happen to be idiopathic. So when we're talking about the management of a blister in the inflammatory category, a biopsy and tissue culture is particularly important and appropriate. When we're talking about pyoderma gangrenosum, this is a diagnosis of exclusion. So we do need to rule out that this is not a neoplasm, that this is not due to an infection, and it's really a diagnosis of exclusion. Because it is a reactive process, well, we need to know what the underlying cause is, because if we don't treat the underlying cause, the blisters or the cutaneous process will be tends to be constant. So you'll need to treat the systemic disease, and that may be through anti-infectives, anti-inflammatories, immunosuppressants, and a bunch of our colleagues may be useful and helpful. And then after you've treated the underlying systemic problem, that's when you'll be able to treat the cutaneous inflammation, because it tends to resolve with systemic disease, but because it tends to be more inflammatory, topical steroids or antibiotics that have anti-inflammatory properties can be useful. Case 5. So this is possibly very commonly seen on the ward. This is a 60-year-old man who presents with chronic renal failure. He's been hospitalized and immobilized for weeks. He's had this gradual onset of tense, asymptomatic, non-inflammatory blisters, and they happen to be on the lower legs exclusively. He has pronounced pitting edema and anasarca. These are edema blisters, also known as stasis blisters or hydrostatic blisters, and they're quite common and they're not dangerous, of course, in terms of the skin. So when the legs become very swollen, this is often due to an acute exacerbation of chronic edema for several different reasons. A slightly poor comparison is that these legs, they become so inflamed that they may be compared to those of an elephant. So this is a condition called elephantiasis varicosa nostra. So hopefully we don't need to use that diagnosis too often. And so why do they develop? It's because of the underlying edema. And why does the edema develop? You might know better than I. But basically, if we look at the basics of it, when the capillary filtration rate exceeds the lymphatic draining, there's a net movement or accumulation of fluid in the interstitial tissues. So that can happen in the lungs, but it can also happen in the skin for a variety of reasons, including heart failure, renal failure, liver failure, low albumin, venous occlusion, certain medications that can cause swelling, for example, calcium channel blockers, or acute lymphedema. And the classic presentation is a very bland, superficial blister, but it tends to be quite tense and large. It's no pain, but that key is that there's really a lot of surrounding edema. And it tends to happen in mostly the dependent areas, like the legs, the dorsal feet, and the ankles. And they generally resolve once the edema is improved. It's a reactive process to the edema. So we sometimes need to use treatments like diuretics, if it's feasible, stop the calcium channel blocker if possible, if we suspect that that's the cause, elevate the legs, and of course, compression dressings if their heart can take it. But it's not always that simple. So you may have blisters on the lower legs exclusively that also look non-inflammatory, that are asymptomatic, non-painful, and they're not due to edema blisters. They have none of those risk factors and all their internal organs are fine. But for example, this patient happens to have a history of diabetes, similar types of asymptomatic non-inflammatory blisters. This is actually a case of bullosis diabeticorum, which can look almost exactly the same. Very poorly understood phenomenon. It's not very common, but it has been the presenting phenomenon for patients with diabetes in the past. Some suggest that it may be due to a microangiopathy because it's associated with a polyneuropathy. The prevalence is unknown, tends to happen around the age of 55. And again, have those similar type of presentation with those tense blisters that vary in size. They seem to improve on their own, so you might never see them. They are benign technically, but because the patient has underlying diabetes, a separation in their epidermis might make them more predisposed to infections. So of course, if you're suspecting that this is blisters due to diabetes, that might not be the only factor you'll be looking at. In fact, there's a lot of skin cutaneous clues that'll help you to diagnose diabetes. For example, thickening or a velvety hyperpigmentation of the posterior neck or folds called acanthosis nigricans. Patients might have a wide variety of pigmentation in the axillae or have acrocordons or skin tags. They may exhibit the prayer sign due to glycosylation of the collagen. They may have ulcers of a yellowish type on the shins called necrobiosis lipoidica. If their triglyceride levels are highly elevated, type 1 chylomicronemia, they can have eruptive xanthomas. They may have a diffuse induration or erythema of the upper back. This is called sclerodema. And although this is not exhaustive list, but a wide variety of other factors that might cause glycosylation within the skin, for example, granuloma annulare. If they have additionally these signs and that blister, then you might suspect that the underlying cause is diabetes, but you might have come to that conclusion much sooner than that. Still, there are some bland blisters that are due to a wide variety of intrinsic and extrinsic scenarios. For example, patients that are hospitalized for long periods of time and immobilized due to pressure and local hypoxia. These are coma blisters. In patients who have repetitive trauma, they may be young and active, or athletes, or they buy a new pair of shoes. Friction that causes superficial blisters that easily denude and be quite uncomfortable and painful. And still, you might have exposed on yourselves. You might have had a bad sunburn that causes a bunch of little blisters, but they can be quite prominent. But I do want to point out that some people have a genetic susceptibility or predisposition to having bad sunburns. And for example, if you have a low level of a hepatic enzyme called uroporphyrinogen decarboxylase, you might be susceptible to having not only the sun damage from ultraviolet radiation, but those blisters in a condition called porphyria cutanea tarda. Case 6. So we're getting more and more severe. This is a 75-year-old man who has a rapid onset of intense pruritus. He has widespread tense blisters on normal and erythematous or red skin. Some blisters deroof, leaving eroded skin. This is bullous pemphigoid. And bullous pemphigoid is possibly the most common autoimmune subepidermal, which means tense blistering skin disease. Usually chronic, sometimes have spontaneous exacerbations and remissions, but it can be accompanied with significant morbidity, as you can imagine. Predominantly affects our wiser populations over the age of 60, 6 to 13 new cases per million population per year. Men seem to be a little bit more affected than women, very rarely in children. In terms of the pathogenesis, it's caused by an IgG, a circulating or tissue-bound IgG autoantibody that targets these structures within the hemidesmosome, which we saw earlier. So ultimately, the entire epidermis lifts up and creates those tense blisters. In so doing, it also recruits complements and eosinophils and neutrophils that release proteolytic enzymes and ultimately suppress or separate the epidermis even more than the dermis. Here's an example at the histological level where you can almost see all these little eosinophils lining up at the level of the subepidermal junction, releasing their proteolytic enzymes and lifting up the entire epidermis. And so that's why those blisters tends to be quite tense. So the classic presentation is to have those tense blisters on that red skin. It can be 1 to 4 centimeters or even bigger in some cases. They tend to persist for several days, leaving erosions or crusts. And interestingly, they seem to be a little bit more common in the flexural areas where there's a bit more friction. Now, patients may not actually have any blisters. They may have an eczematous presentation. They just have that intractable pruritus, either alone or excoriated, and it can persist for several weeks and even months before any blisters develop. You may also have an urticarial presentation or a hive-like presentation. So they only have hives, but they tend to persist in specific areas, and you can almost see that there's a looming blister developing. And finally, they can spread very rapidly. It can be quite drastic presentation. Some patients may have oral involvement. About 50% of patients happen to have peripheral eosinophilia, and that is the cell that tends to create a big portion of the problem. A bit of a question that's mostly meant for the graduating dermatology residents. What are the clinical variants of BP? There are many. For the purpose of this talk, we'll just go a few of them just so that you're aware. There are forms that affect the hands exclusively, almost like dyshydrotic dermatitis. We call this dyshydrosiform pemphigoid. There are some vegetating subtypes that eventually create crusts in the folds. There are some that are so itchy that it only have inflammatory bumps like prurigo nodularis. Some very severe forms that almost look like toxic epidermal necrolysis or TEN-like BP, and certain specific variants that sometimes happen in children that may be very focalized or localized, for example, in the genital region. And for our derm residents, I guess again, pemphigoid incipiens is a pretty precise variant, which requires a very high index of suspicion because these patients have absolutely no blisters, they have no redness, but they're quite elderly, and we suspect that they might have bullous pemphigoid. The only way to confirm that is to do a blood test and see if they have circulating autoantibodies. But internal medicine does need to be aware that there are associated diseases with bullous pemphigoid. In terms of malignancy, we do think that there's an association with malignancies, maybe primarily due to older age of patients, because the case control studies only show a marginal increase in malignancies. So we do still recommend screening for age-appropriate or age-related cancers, as in the general population, for breast, GI, and prostate. It is considered to be an autoimmune condition, and it might create a susceptibility to autoimmune disease. There are reports of inflammatory bowel disease, Hashimoto's thyroiditis, dermatomyositis, and lupus. It can be linked to other cutaneous diseases that share pathogenesis within the dermal epidermal junction, like lichen planus and psoriasis. Interestingly, it seems like that level of BPAG1, which is in the heavy desmosome, may be expressed as neuronal variants within the central nervous system and peripheral nervous system. So there are suggestions that bullous pemphigoid may be linked or associated with Parkinson's disease, dementia, and multiple sclerosis. And finally, drugs. BP is considered drug-induced until proven otherwise. There have been several reports of furosemide, Lasix, certain analgesics, penicillamine historically, and ACE inhibitors like captopril. Now, the role of the dermatologist is quite difficult when we're seeing pronounced autoimmune blisters. This, for us, might look like classic bullous pemphigoid, but so might this. This is a patient that has inflammatory bowel disease and mechanobullous blisters, and it's not at all BP. This is epidermolysis bullosa acquisita. This is a patient that, again, looks very similar. They also have IBD, but they come as a sort of like a string of pearls, not bullous pemphigoid whatsoever. It's linear IgA. Again, very similar presentation, has an underlying history of celiacs. This is dermatitis herpetiformis. And finally, this patient, again, looks very similar on a background of erythematous skin. They have a malar rash and arthralgia and Raynaud's. Might have guessed it, this is bullous lupus. But you can anticipate that the role is not easy in dermatology when we see these different presentations. We need to do more investigative work. So we'll try to do a biopsy. We'll see that all these processes are subepidermal process because the blisters are quite thick and tense. And we're looking for the underlying cell type. Bullous pemphigoid, mostly eosinophils. LABD, or linear IgA, mostly neutrophils. Same with dermatitis herpetiformis. In EBA, luckily, you might not see any cells whatsoever. And in bullous lupus, you might see more of a lichenoid infiltrate and maybe some neutrophils. So we haven't gathered enough information to properly distinguish all of these. So we have to do one test further. We do what's called a perilesional biopsy, so taking tissue right outside of the blister to see what type of process might be impending or coming about. So if we do a direct immunofluorescence, we can appreciate that at this process, the level of involvement is purely at the level of the dermal-epidermal junction, really where the epidermis sits onto the dermis. Still, many things can do that. So we have to separate the tissue by adding a 1 molar solution of NaCl and ultimately identifying where that antibody tends to localize. Does it localize to the roof of a blister or does it localize to the base? And so that helps us to identify certain factors. So for example, bullous pemphigoid would tend to localize to the epidermis, and cases of lupus would tend to localize to the dermis. So if we look at these again, we can properly identify that, okay, they all look like similar blisters, but at least I've gathered that there's different forms of cells in each of these blisters. And now I know bullous pemphigoid goes to the roof of the blister. LABD goes also to the roof, but has a different cell type. Bullous lupus goes down to the dermis. EBA also goes to the dermis, but a different type of cell. And finally, dermatitis herpetiformis is a completely different phenomenon. Although it's IgA mostly, it tends to occur in a granular process. So the dermatologist's role is not exactly easy in that process. Once we've identified that this is clearly bullous pemphigoid, we have to understand and explain to patients that this can be a condition that has a significant morbidity. And they can go into clinical remission, but there still is some mortality, 10 to 40%, depending on the severity of the comorbidities. The treatment is mostly grounded on clinical experience. It seems like the best protocol still is a rapid anti-inflammatory therapy of prednisone, 1 milligram per kilogram. And then once it's tapered over, it seems like there's no clear consensus guidelines as to how long patients will need to be on steroids. In fact, a lot of patients need lifelong 5 to 10 milligrams of prednisone. And so those patients obviously need special attention for those corticosteroid side effects, particularly with attention to calcium, vitamin D, bisphosphonates, GI protection, and cardiovascular and diabetic complications. There's also a wide variety of patients that might not respond to prednisone, so other immunosuppressive medications have been used and reported, particularly azathioprine, mycophenolate mofetil, methotrexate, cyclosporin, IVIG, rituximab. In patients who have scarring processes, particularly around the mucosal sites, like around the eyes or the mouth, this is called cicatricial pemphigoid. These are rapid emergencies, so we want to prevent the scarring. These patients may require specific cyclophosphamide to repair more rapidly, or rituximab. But if the underlying cell is a neutrophil, dapsone might be more appropriate. Case 7. This is a 60-year-old man that presents with flaccid blisters, so different than bullous pemphigoid, which detach very easily, leaving eroded skin. The erosions themselves are quite painful. They're becoming more and more widespread. There also happens to be a quite characteristic erosion at the base, at the peripheral palate. This is pemphigus vulgaris, different than pemphigoid. And the process is different because basically we're targeting intercellular cells within the epidermis, and there's no involvement or rare involvement of the hemidesmosomal area. A little bit less common, 1 to 5 new cases per million per year. Seems like it's equal in both men and women. Seems to be a little bit higher in patients of Jewish ancestry. So again, if we're looking at this being an intraepidermal blister, then the blister formation is much more superficial. And you can appreciate the pathogenesis through a direct immunofluorescence. You can see here that each keratinocyte, skin cell, is surrounded by an inflammatory process or target. So this is called sometimes the chicken wire pattern, which comparatively to bullous pemphigoid is very different. We're only targeting the dermal epidermal junction here, and here the entire cells of the epidermis can be involved. There are different forms of pemphigus. We don't have time to review them all. There is the common type, the foliaceous type, which we saw in the beginning of the presentation, and importantly, a paraneoplastic form of pemphigus. All subtypes essentially have an oral erosion, which tends to be quite painful. It's due to desmoglein 3, which is a little bit deeper in the epidermis as compared to desmoglein 1, which we talked about at the beginning. The oral erosion may actually be the only feature. So in dermatology, we might not even see these patients. They might only be seen in oral pathology or dentistry, but because of the widespread mucosal involvement, they can have esophageal hoarseness and dysphagia. 50% might have cutaneous lesions, and that's usually when dermatology tends to see them, which are quite easily deroofed blisters. And unlike bullous pemphigoid, patients rarely have pruritus. Now, you might have heard of this sign called Nikolsky sign, which is often written on our reports, especially for dangerous eruptions of the body. Basically, the concept implies that if we use lateral pressure of a finger onto the skin, if it easily falls off with your finger, then you can suspect that there's an impending blister formation. If conversely, you happen to press onto a blister and it expands laterally, very similar to the Nikolsky sign or the inverse Nikolsky sign, also called Asbo-Hansen sign, which can also help to diagnose blistering disorders of impending problems. This is also positive in a condition called toxic epidermal necrolysis. Pemphigus vulgaris can be fatal, especially when large surface areas are involved. In fact, because we're looking at an intraepidermal blister, you can almost appreciate that there's sort of a line of residual keratinocytes at the base. Historically, and still today, we consider this called the row of tombstones sign, which was attributed or sort of alluding to its poor prognosis. But now we understand that there are much more therapies that increase survival. So for these patients, very important to rule out secondary infections. If it happens to be painful, make sure there's no underlying bacteria. If it's very painful, it could be contaminated by a virus, and so you might need to use an antiviral. Always rule out an underlying drug involvement, notoriously penicillamine and captopril. A lot of these patients tend to have an immunobolus workup, at least in our clinics who deal with complex dermatology, to anticipate which type of immunosuppressive therapy may be useful. Still, the standard when we want to have rapid improvement is to give a 1 to 2 milligram per kilogram dose of prednisone. And then with the slow taper, you might need to administer a second immunosuppressive or non-cortisone immunosuppressant. Reports of azathioprine and Cellcept have been useful. However, more and more we're realizing that pemphigus happens to be a B-cell driven disease, and so medications that target B cells or its antibodies like CD20, rituximab, for example, has been showing much more impressive results. In fact, here's an example for a patient who's been treated with many therapies, including IVIG, which didn't respond, and then within a couple of weeks of treatment in KC, resolved completely with rituximab. Do want to take a small note with regards to paraneoplastic pemphigus, which may present exactly the same way, however, tends to have a much more intractable stomatitis, and the malignancies you need to look for, particularly non-Hodgkin's lymphoma, chronic lymphocytic leukemia, and Castleman's disease. But there are other malignancies that can that can cause this, namely thymomas, sarcomas, Waldenstrom's macroglobulinemia. And so the treatment for these cases is primarily to treat the malignancy. If you don't treat that, of course, the skin will never get better. But unfortunately, that intractable stomatitis might still be resistant even after the malignancy is improved. We have a little bit of time left for the last case. This is case 8. This is a 65-year-old patient, a female who took Septra 2 weeks ago for a UTI. She was initially fine, and then she started developing some tense to flaccid, painful bullae with fever, and she has a positive Nikolsky as evidenced by the arrow here. Then she rapidly deteriorates. So she develops mucosal involvement, genital involvement, rapidly detachable skin. This is a cutaneous emergency. This is toxic epidermal necrolysis that you might have heard of, sometimes referred to as acute skin failure, historically as Lyle's syndrome. Definitely important to be aware of this. In fact, there happens to be an overlap. Some people will identify Stevens-Johnson syndrome as similar to TEN, but a much less body surface area involvement, less than 10%, versus TEN generally embodies at least 30% body surface area involvement. So this is toxic epidermal necrolysis. I'll call it TEN for now. It is rare. It's an acute but life-threatening disease characterized by fever, severe mucocutaneous tenderness, erythema, and extensive exfoliation. It's almost always drug-related, 7 to 21 days after a first exposure, but it can be infection-related. In fact, there are reports of COVID causing this, and infections can cause Stevens-Johnson, particularly in children. Vaccines can also cause this. It is still luckily very rare. The statistic is about 1 per million population, but the mortality rate is about 25 to 35%. Happens to be in more elderly populations, particularly in women. Other risk factors, people who have slow acetylator genotypes, AIDS or immunosuppression, much higher risk, and patients who either take concomitant immunosuppressive medications or who have a genetic susceptibility or HLA subtype that makes them more at risk of developing TEN. The most common medications that cause this, notoriously allopurinol, antibiotics, particularly of the sulfa and penicillin category, antiretroviral medications, anticonvulsants, NSAIDs, and sulfas. The pathogenesis is a little bit more complex, so we don't have much time to discuss this, but basically you have an increased expression of fast ligand causing apoptosis, then cytotoxic T lymphocytes cause necrosis, and ultimately the production of what's called granulysin, which causes further separation of the epidermis from the dermis in a full thickness form of necrosis. It can be quite destructive. So just so you know, initially the patients may have plain fever and stinging eyes and no cutaneous features for up to 3 days. Then eventually the lesions start to develop on the body. They're quite dusky red, dark red, and they can spread to the neck, the face, the proximal extremities. They might actually look like targets or what we call atypical target lesions. They might actually present with photophobia or painful nicturition, and then eventually you start noticing mucosal lesions in the eyes and in the genital region. But even subtle signs, you have to have a high index of suspicion, especially if they've been on a medication that can be linked to that, because they can drastically change. This is within 24 hours, and these blisters can drastically change into this scalding cigarette paper-like phenomenon. So if nothing else from this presentation, please understand that TEN is a dermatologic emergency and prompt evaluation by dermatology is necessary. In the acute setting, you can have rapid water loss or poor thermoregulation. Some patients may have respiratory tract epithelium involvement, so acute respiratory distress, renal failure, GI lesions, anemia, hypoalbuminemia, encephalopathy, cardiomyopathy. The most common cause of death, of course, is sepsis due to the impaired skin barrier, and death in 25 to 30% of patients. In the long term, because of the chronic scarring, you can have eruptive nevi, you can have dyspigmentation, you may have dry mouth, dry eyes, dry genital regions, phimosis, scarring, and chronic respiratory problems. So our role is to basically identify the prognosis based on which culprit drug it is or causing it, and ultimately find it. There's still no in vitro test, so our role is to do a drug chart or a drug timeline. And we basically use probabilities of medications that are known to cause drug eruptions based on their timing. So we generally look up to 2 months prior to the drug onset based on the severity of the drug eruption, and ultimately we'll evaluate with you which drugs are unlikely or possible, plausible, probable, or very probable of being associated to that condition. Because TEN is a long ongoing process, we generally look at medications at least 21 days prior to first exposure. But remember, if it's a re-exposure, the eruption can occur within 2 days. We do have what's called a score 10 to evaluate the prognosis of a patient. If their age is over 40, if they're tachycardic or have a comorbid malignancy, if they have widespread involvement, obviously much more severe case. And in terms of their laboratory workup, a high BUN or glucose or low level of bicarbonate, which is suggestive of metabolic acidosis, tends to be much more severe. We send for an urgent biopsy. We often have to speak to the pathologist on call and sometimes ask for specific markers that will help us better identify the TEN. At the MUHC in dermatology, our TEN protocol is often to admit the patient either to the ICU or ideally to a burn unit. This is the best setting for supportive care to manage hypovolemia or the electrolyte imbalance. We often need help from our colleagues in ophthalmology, in urology, gynecology, respirology, physical therapy, because there can be contractures due to the collagen scarring. We do that score 10 on day 1 and day 3 to estimate the prognosis. We ask for skin cultures every 2 days to protect from secondary infection. We suggest wound care dressings, particularly non-stick. We talk about analgesics because it can be quite painful, but our main goal is to arrest the cytotoxic process as quickly as possible. Still, there's no specific therapy, but we do recommend still intravenous immunoglobulin at a 1 gram per kilogram dose for at least 4 days. In those cases, for example, this is a patient that was quite severe, and within 3 weeks after IVIG, they can still recover. So these look like terrible cases and still, unfortunately, has a lot of scarring, but it's much better. But because it's so aggressive, we do try to hit them with everything we've got. We sometimes need to add cyclosporin if their kidneys can handle it, maybe even a dose of an anti-TNF like Enbrel. And wherever possible, if you have a suspicion that a patient might be on a medication that's known to cause TEN, for example, a Han Chinese patient who is exposed to allopurinol, if they happen to have the HLA-B star 5801, then of course they're much more at risk of developing TEN or severe drug eruption. So whenever possible, try to test for them or consider giving another medication for gout, such as febuxostat, if of course feasible. So hopefully I haven't provided too much information. I know we're running out of time, so I just wanted to resume in summary. We've looked at blisters that have variable presentations, and they're often quite challenging to discern. Some of them are banal and some of them are a little bit more involved. In general, remember that flaccid blisters, for example, pemphigus vulgaris, are due to an intraepidermal process, whereas tense blisters usually imply a deeper process under at the subepidermal level. This would be pemphigoid. The urgency of blister evaluation depends on the suspected cause and the extent of the disease. As you've seen, that there are genetic forms, inflammatory, infectious, allergic, neoplastic, and autoimmune subtypes. And widespread blistering disease can have a profound impact on morbidity, mortality. So now that we understand our role not just dermatology, but as a multidisciplinary role, it is important to refer to us as early as possible when feasible.
Thank you. Thank you very much, Mathieu. Really, really extensive review, very interesting topic. And thank you very much for sharing these wonderful cases and pictures with us. We are out of time, so I will have to close the official session, but I will ask people to you can enter your questions in the chat. And Mathieu, if you can just put yourself on the mode where you see the chat, you can enter your questions in the chat to have, if you have any questions for Dr. Mathieu Powell. Thank you everyone for joining us, and otherwise have a wonderful afternoon. And thank you again, Mathieu, for this wonderful overview of wonderful dermatological cases. Thank you.
Thank you. I'll see if there's any questions. It doesn't look like